Right, so we're going to talk about mallet fingers. At the outset, I must say I don't like mallet fingers. I'd rather get a very bad comminuted distal radius than get a small mallet finger, because then I have 6 weeks of trouble in my OPD. So there is a classification called the Doyle's classification, little complicated, so we'll try, because I can't seem to remember too many things now. As time goes by, I get little more practical in my approach, and so I need only 2 things to remember when I see a discal fracture. Number one, whether there is a bony fragment or whether there is no bony fragment. So is it a soft tissue mallet or is it a bony mallet? So that's my primary distinction. Okay. So once I do that, I think the soft tissue ones I'd rather put into a splint, but not in a splint like this. So all these splints we've used over the years until I came across Hemant Patankar's lovely little splint that he uses, and we've been using that ever since. Earlier, what I used to talk a lot about was giving a plaster with the PIP joint in flexion and the DIP joint in extension. So whichever finger it is, the patient bends it like this and pushes it up like this while I put the plaster cylinder on, and the patient holds the reduction. And that's a brilliant way of doing it. Patients don't like it. Yeah, so you get a good result with that. Now, why do you get a good result with that? I hope this video works. Yeah. See, when you flex, you can see that little gap there. You can see the little gap there. When you flex the PIP joint, see what happens to the gap? The extensor tendon moves forward. There's more space for it. The lateral bands are relaxed, so they can go forward. So therefore, the 2 ends can come together. So PIP joint flexion is good. This is in a cadaver, but this is what really happens. But patients don't like it, so we need to think in terms of a better splint. And this is Hemant's slide. So we then got these splints manufactured by one of our guys, and now we get it. This is available from J. Ross, and it's probably one of the finest splints for for mallet fingers. Okay, how do you decide if the patient can be treated conservatively and when do you operate? So again, only 2 things to remember. Is there partial extension or there's no active extension at all? So what you do is you tell the patient to, from the mallet position, to go up. And if there's a flicker of extension, that means some fibers are still there, something is holding, there is a good point in trying to treat it conservatively. Suppose there's just no movement, then you obviously think in terms of an operation. Okay, so that's where the problem is. So here's a patient with a 4-month-old soft tissue mallet. When you open it, you find that the 2 ends are lying separate, and it's been avulsed right from its attachment. So a small anchor has been used, and the tendon is repaired again, and you can get an excellent result in that, right? Here's a thumb that had a similar kind of problem, and you can see how it's separated completely. So there won't be a flicker of movement in this one. So in this one, you obviously need to bring that tendon back, and you need to stitch it. So you can use any of the methods, and here's the silver skewed kind of suture which goes back and forth in the figure of 8 to get it nice and strong so you can start early movements, and you can then get a good result. So you can get a very good result in that. So it's not only the extension, you must always look for the flexion as well. Uh-oh. I checked this yesterday, this was looking good. This is a very, very bad mallet where we've used an anchor, and don't use anchors like this. This is a big anchor, should not have been used in this. A micro anchor needs to be used. At the time when I did this, there were no micro anchors. Splinted, went on to do well, but that anchor is going to cause a lot of irritation. It's not possible to remove that anchor. It's very, very difficult. What happens when they come to you late? So we're talking about all the soft tissue ones still. When they come to you late, then there are different ways of repairing it. Now when you see this, there's very little that I want to do with the bone. I don't want to break that bone, put it back, do something. So I'd rather just tighten up the reins. So I tighten up one side and I shorten the other one. I reef one side of the lateral band, and the other side lateral band, I cut it and actually stitch it together. So one has to heal and one is just reefed, and you can get a fairly good result in that. So these are things that you can do. There are so many reconstruction methods. All of them are way beyond my technical expertise. I do a simpler procedure, something like this one. Coming to bony mallet, again only 2 things to remember. Number 1, is it reducible? Is it not reducible? Is it reducible? Then you can use a splint, and otherwise you don't need to. Now this one is asking you to fix it. Please fix me, please fix me. This looks like a nice big chunk. You open any text and it'll tell you 20% or 30%, 30 to 50%, and more than 50% of articular surface. Some talk about 1/3, 2/3, and 3/3. All complete nonsense. What I do is a very simple test. This is the same X-ray. I just put my thumb on top of the fracture site to hide it away from my eyes, and then I look at the joint. What is wrong with the joint? Absolutely nothing. Why not treat this conservatively? Now I've kept my finger on the other side. This is what is telling me, go and operate, go and operate, go and operate. So look at what you're looking at, understand why you want to fix it, and then decide whether you want to treat it or not. So here is a conservative treatment for a bony mallet, which looked more than 50%, which didn't need any fixation. Sorry, but sometimes there's little more things to remember. Number two more, what is the size of the fragment, and is there subluxation? Right, so these are the studies which talk about this, that, and the other, how many percent and all that, but it's all complete nonsense. You have to see each one and see whether it's reducing in a good position or not. Subluxations have to be reduced and maintained. So most important. So here's a trial of what a splint would do. 3-point pressure, cannot reduce it. Maybe late, maybe whatever the reason. If it can't happen, you need to think in terms of something. So here's one where it's avulsed, it's a large fragment, it's moved out. So first you reduce, try and maintain it, and then you mobilize it. So here's the 3-point pressure, and if you see now, the fragment is coming much closer. You look at the articular surface, don't look where the fragment is. See the articular surface separation? Coming so much closer. Therefore, you conserve it, look at the gap, splint given, week 2, much closer, week 3, in place. So if you monitor them correctly, you can get an excellent result. So conserve a bony mallet only when you can do all of that, right? Finally, when you come down to open reduction, the Ishiguro technique is probably one of the finest, simplest, easiest way to do this. What you need to do is to exaggerate the mallet so that the lateral bands can slide over as much as possible, then trap them there with these 2 wires or 1 wire, and then bring back the finger and pin it down, and you can get a good result. So this is how it's done, and you can get an excellent result. So I like that. But it does not allow you early mobilization, but it guarantees that the fragment will stay where it should stay. Okay? When you have to intervene, then you can fix it down with various methods, but be sure that the method is effective. This one was not. I had to redo it and push it back in, but then gave a good result. Don't fix with multiple wires that are completely useless, which are not in place. I've done far too many of these. I hate mallet fractures because they sometimes don't behave the way you want, and they always look very funny at the end and don't give you good results. When you're doing it, you have to again think in terms whether you want to fix it down with a screw. I've borrowed Hemant's slide here. I still haven't done a very good one that I can replace his slides. This is about 7 or 8 years ago that I borrowed this slide. I continue to use it because it completes the lecture and it shows that you need to be as good as Hemant to do this. But you must remember the principles because it's absolutely essential. You have a good fragment that is at least 3 times the size of the diameter of the screw head, and that you catch the opposite cortex. You should also not forget the incision. It's not easy to operate on this part of the finger because the blood supply there is extremely tenuous, and you must use, and I use the first one because it's a good 2 flaps that open out, so an edge-shaped incision, or sometimes in one of the cases I showed the one on the right side, a curved incision but a gentle curve and the full thickness flap raised on both sides. Very, very important. There are small hook plates, or you can devise these little hook plates from material that is already there in your handsets, but I don't think I would try to use them in Indian fingers because they're very thin skin there and it's not going to be possible. 2 things to remember when you're thinking in terms of rehabilitation. Number 1 is that you must have continuous splinting for at least 6 weeks and then night splinting for another 6 weeks, which basically means 3 full months of treatment of any mallet finger. You must assess them, and you must remember that a fair outcome is one where there's a little pain and there's 10 to 25 degree extension lag. So Crawford's assessment says fair result is if there's a 20-25 degree extension lag. So don't worry. Even if you have a little lag, it's a good assessment. The pain should not be continuous, pain should not be persistent. If there's no pain, this is a good result. Right? So finally, remember, complications of treatment, of conservative treatment, are easier to treat. They are transient, usually skin problems. But when you talk about operated, the number of complications increase tremendously. So you've got to be very, very careful when you want to operate these. So finally, what would I do with a mallet finger? What I would do is, when there's no bony injury, if there is little extension, I would treat it conservatively. If there's no extension at all, I would open it. If there's a bony injury, I would see whether I can reduce it and that there's no subluxation. If I can reduce it, I will see whether I can treat it with a splint. If not, I would use the Ishiguro technique. And if it's a larger fragment, I would think in terms of putting in a screw. Thank you very much.